Very good morning, and thank you for this very kind introduction and for this really brilliant opportunity and this honour of being invited here. Just to see. Yes. I think perfect. Yes. So it's been really a real pleasure to be here, and I think I've been treated to some fantastic Australian hospitality over the last week, which has really been outstanding. And it's such a pleasure to be here with a group of families that, of course, I see in my day-to-day clinics every day, but you're all coming together and to build this network across this continent is fantastic. You know, I think it's a real empowerment to actually meet each other and to drive things forward. So what I would like to do today is really give you some of the glimpses of new treatments that are emerging now and that really follow on from these early developments of discovering the human genome and how things actually are moving on. We can actually now see how things are moving on, which is really quite exciting. So what you can see here is the University of Glasgow, and this is our new children's hospital in Glasgow. So I was very pleased to see here that your winter is like our summer. So it is very nice to be here and catch some sun. So just to give you an overview I'm going to talk a little bit about the advances in genetic epilepsies, some prediction tools, which I think quite important, particularly if we think about early treatments, and there's lots of developments that still need to happen in this area. Then some new therapies. I think this is very exciting to talk about some of the new therapies, and then also about how do we lay the groundwork for this in terms of natural history studies and how important that is. And I would really like to go back to some really important work that's been done and concepts that have been developed here in Melbourne. So you have, if you think about 40 years ago, Hauser and Collins really defined all the epilepsies. You had three-quarters of that were classified as idiopathic. And in medical terms, if you mean idiopathic, we don't really know what the cause is. But of course now, fast forward, this is work by Sam Berkovich and Rhys Thomas, who was a fellow here, who's now back in the UK. But actually that this huge part, the three-quarters of the epilepsies actually have some form of genetic origin. And this might be either a single gene mutation or it might be a number of different genetic changes. But clearly, genetics is the way forward to explain the epilepsies. And what we've seen over the years now, so you can see over the decades, these are all the different single genes that have been discovered to cause a form of epilepsy. And you can see how this exponential rise in different disorders. Now we've reached 1,000 different genes that are all responsible for causing different forms of epilepsy. And I think throughout this talk as well, you will see there's lots of, although I might talk about one or two different diseases, but actually all these concepts apply to all the different monogenic epilepsies and are all very relevant for all of you here. And this is a very nice overview that Ingrid put together with colleagues, really defining, looking at different syndromes and epilepsy presentations and how they might be explained. And again, you can see that here, wherever you've got the little DNA here, you can see lots of genetic causes for these different epilepsy presentations. And here on the right, you can see how this actually, once you figure out what the genetic change is, you get to the cause of what actually might cause this epilepsy and what is the mechanism. And once you understand the mechanism, you can then think about how can we actually treat that or how can we make a difference. And this is just illustrated here, all the different mechanisms that are involved in this area. And what we've seen over time is this just an example of how things have been moving on and how precision medicine for genetic epilepsies has evolved with time. And by precision medicine, we really want to get to the heart of what is the original cause and how can we reverse it and how can we advance science. And this goes from, at the top here, from gene discovery, and then that facilitates for you to make a diagnosis. Then you want to learn about this disease and be able to describe it much better. And then you really want to go into drug discovery and how can you actually treat it and how then to go into trials where you actually develop new treatments and then apply that and want to make a difference. And I think here some of the key accomplishments here have really been driven by the Melbourne team. So you have here, for example, all the gene discovery. It's been fantastic how this team here has, and with worldwide collaboration, has driven this forward. But there's still key challenges of we don't really still understand the complexity of genotype-phenotype association. Somebody mentioned earlier that they had a gain-of-function SCM1A mutation, which we only recently described, which had existed for a long time. Actually, now we're only starting to learn about this. There's so many new stories that we still don't understand. Then, of course, we've had now the accessibility of testing has advanced significantly. So if you think about the Human Genome Project and how expensive that was, that now we can actually sequence the genome for a few $100. So it's much, much cheaper, but we have lots of parts of the world where we have no testing whatsoever. So we just did a big survey across worldwide, about 6 continents, and we can see that actually large parts of the world have no access at all to genetic testing. Yeah, and that really, we need to change that. The natural history studies, we need to learn much more about. So we've been very good at describing the genetics, but we haven't been really diligent and good at describing the clinical features. And I think an exception is Ingrid's work for many diseases, really to establish a really good and very rigorous clinical description, which makes you learn so much more about the disease. Yes? And this is something that we really need to drive forward now. And then, of course, drug discovery and clinical trials. Now, one of the things that you would have noticed here, all of you sitting here, there's, as a group, you're many, but as single disorders, there's only a few of you. So how will you run a clinical trial where there's only very few? So we have to think about how can we do different trials, like N of 1 trials, or trials that actually apply to rare disease. This is still something that we need to work on. And I think a really impressive story is that of SCN8A related disorders and what happened over time. So this is a sodium channelopathy, meaning that those are called as epilepsy, presenting early on in life. But this was only discovered in 1995. The association with epilepsy was only made in 2012. And since then, we've had a family organization being created, funding being generated, and within less than 10 years from discovery that is called as epilepsy, going on to ASO therapies for this disease. Yeah, it's been less than 10 years. We go from discovery that this exists to actually treatment or precision treatment. And that's really the pace that we're seeing now, how things are really moving forward really quite quickly. And I think why genetic testing is so important is because it really does make a difference to how patients are treated. Yeah, so this is a large study from the US where actually a large laboratory that performs all the genetic testing, looking at does it actually make a difference to get a genetic diagnosis. And over 50% of cases, they could say yes, because it just meant that a new medication was started, or somebody was referred to a specialist who knows about this disease, or medications that might have been contraindicated could have been stopped. So knowing really empowers you to start the right treatments, to get in touch with the right people, and that's really positive. And if we think about they looked at the different diseases that they discovered, that they tested for, and whether these have had either positive or negative changes. For example, the most common gene was SCN1A and then PRR2, but you can see that overwhelmingly the diagnosis of that mutation led to changes in management that were positive for that patient. Yeah? So you can see that overall genetic testing is a really good thing because it allows you to implement the right treatments for that individual. And now giving this example of Dravet syndrome, that is caused by an SCN1A loss of function mutation. This is Charlotte Dravet, who first described this in 1978. And these are children that appear to be normal when they're born, but around 5 to 6 months of age then present with prolonged febrile, hemiclonic, and generalized tonic-clonic seizures, and then have other seizure types devolving from the age of 1 to 4 years onwards with myoclonic jerks, artificial absence seizures. And what then becomes apparent that the cognitive development is not as expected, so probably from the age of 1.5 onwards. And we have this emergence of a developmental and epileptic encephalopathy. That's a really important concept, that it is the underlying genetic defect as well as the epilepsy leading to the emergent DEE, and this is caused by mutations in the SCM1A gene. And so this is, and again, so these concepts really apply to many of the monogenic epilepsies. So it encodes for sodium channel, and that sodium channel sits in the cell membrane of a nerve cell. So here you've got a nerve cell with the body of the nerve cell, and then how it connects to other nerve cells. And what's really important is that you need this channel for sodium ions to travel through, because if they can't do that, the information can't really pass from one nerve cell to the next. But what you saw in the earlier slide, I showed you all the different mechanisms that we have. They all impact on how our nerve cells connect with each other. And whatever defect you have in any of the nerve cells, it will lead to difficulties how our nerve cells interact. And simplistically, if you think about voltage-gated sodium ion channels, so you have got this channel that sits in the membrane of the nerve cell, and you've got the pore, and then you've got what's called an inactivation gate, and you have all your sodium outside. And if arrested potential, meaning when there isn't much happening, the pore is closed, but then in response to a nerve impulse, so then suddenly your pore opens and all the ions travel through. Yeah, and that's really important, because that then initiates a cascade of other information that passes from one nerve cell to the next, and this is how nerve cells interact with each other. And what you need then at the end is that, of course, you need to stop this as well. So you need to open it, and then you need to be able to close it. Yeah, and this machinery really has to work well together. And what we find in Dravet syndrome is actually that often you have a mutation that destroys or impacts on this pore region. So often you then end up with 50% of all your sodium channels not being produced. Yeah, so you have what's called a haploinsufficiency, where basically 50% of your sodium channels don't really work. You only have got 50% that are working, and that means that you have a presentation with epilepsy with lots of different aspects. Yeah, and I think we really have to think beyond the epilepsy. And I think that becomes then very clear here, so that Dravet syndrome is an ion channel disease. Yeah, so this is an illustration of the brain, and you have these ion channels are expressed throughout the entire brain. Yeah, and what we can see, for example, is they're expressed in this particular part. It's called the hippocampus. And in animal Dravet models, what we could see is if you have this mutation, you end up with lots of seizures. So this is a snippet of the EEG, which shows you lots of cardiac activity, so it causes seizures. But what we also know, it's also expressed in the back of the brain, what's called the cerebellum. That's really important for movement, and it's for balance. So what we know that individuals with Dravet syndrome actually are what we call ataxic, are unsteady on their feet. So we have a presentation not just of epilepsy, but also of unsteadiness. And what's really important, that this is also expressed in the front part of the brain, and that's really important for learning, for planning, for thinking, and also for activity. And it's also in terms of how we interact with each other. Yeah? So you can see that this ion channel disease causes lots of different, what we call presentation or comorbidities in one individual, and you will recognize that in your own kids. You will recognize it's not just the epilepsy, there's lots of different aspects that actually your child or your loved one might struggle with, and that is because the underlying genetic defect and the change in the nerve cells will actually generate that particular presentation. And I think I like this review, which looks beyond the epilepsy and the overlapping of neurological and psychiatric phenotypes. So you basically, here's an illustration of different presentations such as autism spectrum disorder, ADHD, seizures, schizophrenia, depression, anxiety, and then you have different genes that are involved in these different aspects. For example, blue are all the genes associated with epilepsy. In green, those with dystonia, which is a movement disorder. And purple, those with autism spectrum disorder. So you can see that then one particular change might actually present with lots of different features, and that's really important, I think. So I've added actually these three here because they weren't there before, so that, of course, you've got lots of different presentation, and that's, so our knowledge about all the different diseases is really important. And what I mentioned earlier, to really understand the genotype-phenotype association means to learn more about the disorder and how it presents, and that's really important. So getting back to the example of Dravet syndrome, here this was a large survey amongst families internationally, over 500 families, really reporting on quality of life and what we call comorbidities associated with Dravet syndrome. And what you can see here is that we've got really high rates of motor impairment, speech impairment, unable to talk, learning difficulties, autism, ADHD type features. And this is where you need to get back to families, for families to actually report these are all the different things that we struggle with, and that's really important to determine. We did, in the UK and in Glasgow, we did what we call a longitudinal study, so where we started to look in 2010, 8, 9, 10, at a cohort across the United Kingdom of individuals with Dravet syndrome, and then 10 years later, we looked at the same individuals 10 years later and what their development and how they got on. And this is here looking at the cognitive abilities 10 years ago and then 10 years later. So what you can see here, whether somebody had an average cognitive abilities or mild, moderate, severe, profound learning disability, and what happened then over 10 years. And this is slightly misleading because what we know in Dravet syndrome is that you don't have what we call a regression, that you lose skills, but you don't acquire skills at the same pace as your children, your brothers or sisters who actually develop normally. So you see that if you, over time, over 10 years, from if you're 6 years old and then 10 years later, 16, you would expect a huge rise in knowledge and in ability, and actually in these kids that doesn't happen. So this gap between the Dravet children and normal controls really becomes ever greater. And of course, we then also looked at other comorbidities and predictors of what might impact on health-related and on quality of life. So we look at, for example, autistic features. So at the beginning, we had about 15% autistic features. After 10 years, 80% of autistic features. Yeah, so behavioral difficulties, huge rise, and also motor disorders. So over time, we can see, and these are really important aspects of how kids present, and it's important not just to focus on the epilepsy, but also to focus on all what we call the comorbidities. And this is a slide that gives you this an overview over time. Actually, this is from birth, 3 months, up to adulthood in Dravet syndrome, and all the different things that then occur. So you've got febrile seizures, status epilepticus, so these are really long seizures lasting 30 minutes or longer, the myoclonic seizures, but here we also have ataxia, we have got crouch gait, we've got sudden unexpected death in epilepsy. So you can see over time, this is a really busy disorder with lots of different comorbidities over time, and I think this is what you've also in all the different presentation of monogenic epilepsies and diseases that you are confronted with, you will see something similar. And what is interesting about Dravet syndrome is, and SCM1A related disorders, that we have different presentations depending on the severity of the mutation in the SCM1A gene. And that ranges from the most severe presentation of Dravet syndrome to actually very mild presentation of febrile seizures. And febrile seizures plus, genetic epilepsy is febrile seizures plus. This was Ingrid's original PhD thesis, and Ingrid's done a huge amount of work on this, distinguishing the two or the different presentations of SCM1A mutations and going from milder missense mutations to truncating loss of function. If you have a truncating, if you think about can you build a protein, if you can't build it at all, then you have what we call a truncation, so it's just not operational. If you have a missense mutation, it means that one amino acid is exchanged for another one, and you might still have a functional protein, but it might not function as well as it should. Yeah, and you can see this gradient. But I think what's really important is here, and lots of questions for physicians, if you have a child presenting at 6 months with the first prolonged febrile seizure, and you do the testing for the SCM1A gene, and you know it's positive, how do you know that your child will either develop Dravet syndrome or febrile seizures? Yeah? So it's really, really important, because if you have Dravet syndrome, that means that you have intellectual disability and lots of comorbidities. But if you only have febrile seizures, that's a much milder presentation, and it's really important. So many people in the past, many groups have tried to explain this and to look for what we call biomarkers or indicators that can tell you early on where the journey might be going, and that's really important. So what we found is this is a Japanese group, and they looked at presentations of children, whether they had an age at seizure onset, and what they found is that in the Dravet group, the age of onset, so an early age of onset, was really important and an important marker for Dravet syndrome versus other epilepsies. And there's other groups from Italy and from the Netherlands who looked at this as well, and they also came up with this idea that if you present very early, this gives you a higher chance. But what we found is that the clinicians weren't so confident really just rely on age of onset alone, and this is where international collaboration is really important, and you need to look at many patients to actually find out and develop tools that are powerful enough to actually give you an impression of how early you can do this. So we did this with a huge international collaboration. We included over 1,000 patients with SCN1A related epilepsies across the world, and Ingrid was part of that, friend, and then colleagues across the world really. And what we did is we looked at the age at seizure onset. That was really important, but we also looked at part of the genetics and whether the genetics and part of the genetics can actually give us an additional information to call a variant and whether this might be a Dravet variant or a milder variant. And when you do that, so now with AI, with machine learning tools, you can actually develop models where we basically had a training cohort of 750 individuals who are either GEF Plus or Dravet, and then we predicted on those informations whether they would develop either Dravet syndrome or GEF Plus. But when you do that, you always then need to prove that this is really able to do what you intend to do. So you need to test it on samples of patients where you don't know the diagnosis. So we did that. So Ingrid very kindly gave us information about her cohort of over 200 patients. And we did it again on the Belgian cohort where we did not know whether the individuals actually had Dravet syndrome or GEF Plus, and we predicted it based on our algorithm to show whether this is actually helpful or not helpful. And what you can see is that when we looked at, for example, the age of seizure onset, so here, the closer you're here to the left, the earlier you present, and the Dravet patients are in purple. So you can see that the Dravet patients present really quite early compared to the milder GEF Plus who present later, but you've got quite a lot of overlap. And then the genetics, again, if you've got a high genetic score, the higher, the more severe. But you can see that the Dravet patients were all clustered on the right-hand side and the milder GEF Plus on the left, but still there was a lot of overlap. But putting the two together was really helpful. And we then tested it on two cohorts. So the top is an illustration of Ingrid's cohort, and every vertical line is one patient, and it goes from here to here. If you're right on the right, your chances of Dravet syndrome are really high. If you're to the left, your chances of genetic epilepsy with Febrile Plus are very high. And then this is the Belgian cohort where we did exactly the same thing. And then we unblinded because we didn't know what the phenotype was. And what we found is actually that our model predicted all the Dravet patients to be on the right and the GEF Plus patients on the left. Yeah? But this is now available online. It's freely available. Clinicians can look at this. You type in your mutation, you type in the age of onset, and that gives you an estimation. What is your percentage chance of developing Dravet syndrome versus developing genetic epilepsy with Febrile seizures plus? And that's really important because you can actually do this at the time of diagnosis when you actually receive your genetic result, because when the seizure occurred and you have your genetic result much earlier. And this now means that clinicians, based on their clinical acumen, but also with the help of this, can then tailor their treatment towards more targeted what they think the problem might be. I think what's really important is that, of course, this model is designed to be used by trained professionals and neurologists to aid the diagnosis of SCN1A-related epilepsies. So it's intended to complement clinical judgment, but not to replace it. Yeah. So what's really important is, so this needs to be looked at by an expert in the disease who actually knows the presentation and can interpret this properly. Yeah. And this will be then your child neurologist, geneticist. And this model applies to loss of function SCN1A presentations. Yeah? But I think it just shows you that in the future, when we think about if we need an early diagnosis and we want to treat earlier, and that applies to any disease, where you think the earlier you treat, the better the outcomes might be. Therefore, developing tools for other diseases as well, where you can actually make an early diagnosis is really important. Now, just focusing on where with Dravet syndrome, particularly where we have evidence-based treatments for Dravet syndrome, and you will be familiar with stiripentol of those who have had an SCN1A Dravet syndrome. That's one of the first drugs to be approved. Then we have cannabidiol and fenfluramine. And what's important to understand here is that there's a whole process of how drugs are actually approved and how studies need to take place to actually establish whether a drug is safe and efficacious. So this starts with what we call preclinical work. So this is all mouse model work. You will see this. If you're interested in what's happening in your disease field, in your particular mutation field, you will see that there's lots of preclinical mouse model work. And when it goes into the human phase, so you've got a phase 1, which is first in human. It means that then it crosses the barrier between animals to them used in human. These are very small sample sizes, and that's really to determine the dose, but also safety. Yeah, safety is really important. And then it goes into different phases, where, again, further analysis on how safe this is, more efficacy, and then it goes into phase 3, which is a placebo-controlled trial, where you basically try the medication and then also have a different arm, that's a sham arm or a placebo arm, so that you can have on larger patient numbers to establish. And you have to go, this is a very rigorous process, and you have to go through all these steps, because what you want is a drug that's safe to use and efficacious to use, and it has to be tested properly. You can't just jump the queue and go straight to something when it's not rigorously tested, and that's really important. So how this works and how this presents in the Dravet field is that at the moment, so we've got different levels of development. So here you've got the different circles, and on the outer circle is preclinical, then early clinical, late clinical, and this is marketed. Yeah, so what you can see here marketed is fenfluramine, CBD, and stiripentol. So those are the drugs that are actually approved, and I've just heard that fenfluramine has just been approved to be administered here in Australia as well. But what's interesting is this lower part here. These are actually disease-targeting or disease-modifying. These are the genetic treatments. And let's say 5 years ago, none of this actually existed. Yeah, we only had, there's 2 drugs now in development and trials, but actually all of these 10 here actually only just emerged over the last 5 years. And what I anticipate that over the next 10 years, this whole disease development field of genetic therapies for any genetic epilepsy will really gather pace and momentum, and there will be more and more products becoming available. And I think if you think about how these new disease-modifying treatments actually work, so you basically you've got your DNA, which is basically the recipe book for all your proteins in your body. Yeah, and every single gene encodes for one particular protein. Yeah, this is like a recipe. And so then the process is that you go from your snippet of your DNA, which is a gene, then this is going to be transcribed in what's called a messenger RNA and then translated into the protein. So what you want is, in the SCN1A example, so you've got the SCN1A gene, but then actually you want to end up with your ion channel, which is a protein. Yeah, and that needs to work properly. And you have different ways of where you can actually make a difference and modulate that. So I explained earlier, if you have, for example, the SCN1A gene, and in Dravet syndrome, you've got one copy, you've got 2 copies, and 1 copy is just not functioning. So if you've only got 50%, how can you make up to 100%? Yeah? So the idea is, can you actually give a new copy of SCN1A and just give that extra? The problem is that this is a very big gene, and protein, so it's very difficult to transport that into the cell. Yeah, so that's difficult, and there's different ways of how to look at that. Then what you can, at the genetic level, you can actually boost the SCN1A gene expression with a transcription factor, for example. So there's lots of different clever ways how to circumvent this. And what's really exciting is that over the last 10 years, we've seen such a development of new things and new techniques to overcome all these different hurdles that we have. Or you can do this further along from the DNA then to the messenger RNA, and at this level you have got the ASOs, and I will focus on a little bit later. And the target is always to produce more protein and to make up this deficit of 50% that we have. So now coming to one of the trials that's now been really running over the last few years, really, and that's an ASO called zuranolone. That's an antisense oligonucleotide under the developer for treatment for Dravet syndrome, and that's what's called an RNA-based treatment, and it increases the expression by blocking a part of the mRNA that normally would lead to degradation. So what I explained earlier, so here you've got your DNA, and here you've got your protein. Yeah? And what normally happens, you've got one faulty copy. The faulty copy doesn't produce anything, and then you've got one good copy. And what you want is this ASO, antisense oligonucleotide, actually makes the good copy being produced more. Yeah? So you produce more of your healthy copy, and therefore you increase your proportion of a protein that you have. And this is delivered via repeated intrathecal, so by repeated lumbar punctures. So what you can see here, so this is a spinal tap. So this is applied by giving repeated doses every few months of this product into the brain fluid, and that selectively boosts the tissues, only in tissues where this is normally expressed. And this is early animal work. This is on mice. So this shows the survival of Dravet mice going forward. And you can see that Dravet mice that are not treated die very quickly, whereas those that were treated with this ASO actually had a really good survival. Yeah, so this is the first step to show that this actually in principle might work, and then you move on to trial this in the human. And here, so these were the first phase 1/2, so first in human studies on safety and efficacy of zorevunersen. And the eligibility criteria these were patients that were between 2 and 18 years of age. They had an established Dravet syndrome diagnosis, and they needed to have an SCN1A mutation. So it's a genetic treatment, so of course you need to have a genetic mutation for this to work. So that was the inclusion criteria. And then you had ascending doses in phase 1/2. You want to look at safety and to want to look which dose might be the appropriate. So you start with very low doses, and then you titrate up to higher doses. So this was from 10 to about 70 milligrams. It was conducted in the US and in the UK. And then after, you can see here, you have these 3 loading doses, and then a pause, and then a dose every 4 months. And that then went into the open label extension, that all those patients then continued to get the same treatment longer term. And we looked at safety and then also changes in seizure frequency. And overall, there were 81 patients that were included. All of them had, or the majority of them, were already on lots of anti-seizure medications. So 50% of them already were on 4 or more anti-seizure medications. You can see these were really patients who were quite treatment resistant, despite being on 4 drugs, still had so many seizures that they qualified to actually be included in this trial. And looking at safety and tolerability first, so we had in the phase 1/2, we had 30% of patients experienced study-related treatment emergent adverse events. So the most often was that the protein in the brain fluid was raised. And this is something that we've seen many times in antisense oligonucleotide treatments before. This is something that's recognized, but it didn't present with any clinical signs. Sometimes you worry that if your protein in your CSF and your brain fluid is high, that this might be associated with higher pressure or headaches, but these patients actually didn't have any symptoms. We noticed this, but there were no clinical symptoms. However, we had one patient that had what we call a sudden unexpected serious adverse event. So that's out of the 81 patients. This was first in human, and you have to be quite cautious because you don't know what will actually happen. So we had one patient who actually had a regression that we couldn't explain by any other ways. We really examined this patient, and we assume it might have been related to the product. And at this stage, we don't know, is this 1 out of 81? Is this 1 out of 100,000? Or is this more common? And this is, on this journey of discovering new compounds, new drugs, there is a risk. And only with time will we learn how frequent that is. And that is why all these studies are really tightly regulated and need to be reported, and you need to really find out what are the benefits and what are potential risks here. In the open label extension, then almost all patients carried forward, and up to 80% of patients presented with this raised protein levels. However, they didn't present clinically, and it wasn't a reason for anybody to drop out there's only one patient where the clinician wanted to drop out because I didn't feel the patient had any benefit or so much benefit, but most of the patients actually tolerated this quite well. So if you then look at efficacy, so this is then looking at here, an illustration, this is the number of, and the change from baseline and seizure frequency. Yeah? So we counted how many seizures the patients have, and what happens over time, did the seizure count actually reduce? And what we can see here is over time, is you've got here in different colors, different doses of medication. And the lowest dose is 30 milligrams in orange, then 45 milligrams in red, and then 70 milligrams in green. And what you can see is that over time, those patients who received the higher dose of 70 milligrams, their seizure frequency really dropped quite significantly, down to about 80% reduction. And these are patients who already were on 4 medications, despite all their medications, had very frequent seizures. And with this new treatment, actually, at the higher dose of 70 milligrams, actually, the seizure frequency dropped quite significantly. And this is just a figure to show how over time, this is again the change from baseline in seizure frequency and the higher dose and the lower dose, and this is actually over 2 years. Yeah? Over 2 years, you can see how this is actually maintained. The reduction in seizure frequency is maintained over time. But what we are also very interested to look at, and I explained that earlier part of my talk, looking at the comorbidities in the other presentations, looking, for example, at cognition. And here we looked at cognition and behavior, and this was with an adaptive behavior scale, a violence scale, and what you can say here, so looking at receptive communication, how well communication is understood, expressive, how well somebody can express themselves, personal skills, coping skills, gross motor skills. And if you have at baseline, any shift to the right is an improvement, any shift to the left is a deterioration. And what you could see from my earlier slide is in Dravet syndrome, what you expect is that over time, actually individuals don't get better. Individuals plateau and don't really improve. And what you can see here is that at 9 months, you see this improvement. And here, these are the improvements seen after 12 months and after 24 months. So we can see that amongst all domains, we can see improvements over time in all these different presentations. And so this is an illustration of a patient that I treated. So it's a 12-year-old girl who here I'll show you first in terms of how she presented with her seizure presentation. So this is her monthly seizure count, and before she was enrolled, she had an average of about 5 generalized tonic-clonic seizures per month. And then she received her first 2 treatments, and what you see is that she received 70 milligrams, and how this works is that once you get it takes about 6 to 8 weeks for your proteins to actually restore themselves. So you don't expect an effect immediately, but you expect an effect to see after 4 to 6 weeks. What you can see here is that after the first 2 doses, then suddenly her seizure count dropped from about 5 a month to 1 a month. And then we had actually a pause in the dosing. And then after time, because the product doesn't stay in forever, so it then washes out eventually. And you can see how then the seizure counts rise again, and then she was treated again in the open extension, and then you can see how that she settled on about 2 seizures a month. And what I show you now is how I filmed her when she was kicking a ball before she was treated. And you can see here, so what you find is in Dravet syndrome you have lots of what we call unsteadiness and ataxia, so she's trying to kick the ball, and what you can see is that she can do that, but it's quite unorthodox how she does it, and you can see that she really has difficulties with coordinating that. And this is now her 8 months after treatment. Yeah? So you can see that basically how she manages that task much better. Yeah, so her posture is much better. We didn't send her to Celtic football school, so this is this is just her being able to do that. She's not cured, but you can see that in terms of her motor development, she's much, much better. You can see that here, yeah? So she just manages that much better. Then, this is now her trying to button her shirt. And what is here, this is in February 2023 at the time of dosing, and this is now, again, 8 months later. And you can see on the right, and so in terms of, that's fairly important, getting ready in the morning before school and how you manage that. What you can see is, on the right, her alignment, her fine motor function, is much better than on the left. Yeah, so she really struggles on the left to align the buttons, to try to button that. Yeah, you can see how she is able to do that with more accuracy, where on the left she gets frustrated there. She can't really do it. And here she even manages to do the top button that she can't actually see. Yeah. And then in terms of fine motor function, this is her writing in 2022, and that's her writing in 2023. Yeah, so you can see how the writing, the accuracy is much better. Yeah, so you can see how that is really much improved. And the next task, I'm asking her to do what's called a finger-nose task. And that's really, so it looks for unsteadiness, but here it's really to see, so she doesn't really understand the task. And also how her interaction is with me in terms of whether she keeps eye contact. You will see on the left, she can't really, she's quite gaze avoidant. And she's still quite repetitive in how she does it. And this is here later.
Wow.
So the way she interacts with me, the way she sits up, she keeps eye contact. Yeah. And then the next task, I was asking her to count. So she hardly looks at me. Yeah? You can just see that the whole interaction with me is different. And also that the parents describe that in terms of how she interacts at the dinner table is just very different. So and that just goes beyond just reducing seizure counts as actually in terms of what we have in the benefits in all the other domains. So this study is now in the open label, so that study is close to recruitment, meaning that the patients were enrolled and now the patients continue to receive the treatment in the open label extension. And what this company now is planning is what's called the first phase 3 study. So this is going to be a study, it's called the Emperor study, and the duration of that study, so this will be a study to show the difference between individuals who receive the ASO and those who have a sham procedure. So in a phase 3, you need to demonstrate that this treatment is better than a sham group, and to show, and how this works is that nobody knows. So neither the clinician nor the patient know who is receiving what, so that you can actually demonstrate that there's a difference. And this will go over an entire year. Yeah, so you will have one patient who will be randomized to the sham, who will then for an entire year will receive repeated lumbar punctures, but not get any treatment. And the other group, and the rationale for that is that the indication here is not only to show that this leads to seizure reduction, but also it has other gains. And to be able to show the other gains, you have to do that via neuropsychological assessments. That can't be done so they have to be done over a certain period of time. So you need almost a year to actually show that reliably. And so this is, and there's now, we discussed that many times, and there will be ongoing discussions because we are now moving in this field. And what is the right approach here? What is the right, waiting for 1 year to be in a sham to then receive treatment, can that be shortened? On which grounds can it be shortened? These are all important discussions that will take place over coming years to come up with the best model how to do that. So this Emperor study will be conducted in the US and many European countries. Ingrid was very adamant to bring it here, and I think discussions are still ongoing, but they're not going to. It's really difficult in terms of that planning. So the primary endpoint is seizures, but then looking at improvements in behavior, cognition, and other aspects. And just illustrating, this is a different approach by the company Encoded. And this approach is not via an A. This is actually turning up transcription and thereby acting directly on the DNA to produce more SCM1A protein. Yeah? And this is given via a one-off intraventricular injection, and that will then is used via a viral vector. And the idea is you give this once, and that then will upregulate SCM1A protein production forever. Yeah? And in the mouse models, so I looked at mice that were treated in this way at the survival. So the untreated mice died much earlier. The treated mice had much better survival. Again, when we looked, so Dravet syndrome presents when individuals are really heat sensitive. At temperature, high temperature will trigger a seizure, and then it's important how resistant you are actually to higher temperatures. And the mice that were treated, so here you can see that the Dravet mice were starting to seize quite early, whereas the treated mice were much more resilient towards higher temperatures. So this shows you that in the mouse model, this looks really quite promising. And this is the reason why this then went into a clinical trial. And this trial is currently ongoing. And patients for this trial are recruited in Australia, in America, and in the United Kingdom. So it's a phase 1/2. So it's very small numbers of patients being recruited. I think there's about 10 patients recruited so far. And we've heard about safety data, so it seems to be well tolerated, but we haven't heard any data on efficacy yet. And this really, because at the moment it's in the phase of trying different doses, different dose levels, and to figure out what might be the right doses to use and that are also safe to use. And this is, again, so it's done by a neurosurgical procedure. The ASO is given by repeated lumbar punctures, but this is given by an intraventricular, so it's a neurosurgical procedure with the injection here. And so we're waiting to hear what this will bring going forward. I can see that I'm over time, so what I'll do is I was just giving some other examples. This is a recent review in terms of precision treatments. You can see all the different genes here, and there's lots of different ways of new treatments being developed, and you will know this for your own genes. You'll know what's going on in terms of the developments and of ASOs being produced. I'm going to skip this, actually. I think where we have to move to is in terms of the journey ahead, really is to look at clinical trial and recruitment feasibility. So we really need to develop trial networks and engage with the community. That's really, really important to develop that. The other aspect is in terms of the clinical picture, so natural history data, this is really something that we need to develop. So if you imagine you're conducting a trial, you have a new treatment, and if you're not just counting seizures but looking at all the other comorbidities, how do you know you're actually making a difference? And if you actually have robust natural history data collected over long periods of time, they can then be used as a comparator to say, actually, we know from a natural history that wouldn't normally happen with a child. If you have an improvement, you can say, actually, this now diverts from the natural history and means that this is an improvement. And clearly what we need is getting trial ready. We need to be able to look for biomarkers. What are certain aspects of the presentation that can give us an indication that the treatment is really effective or not effective? Yeah, so looking at biomarkers beyond the seizure count, and that's really important, and developing that from our ongoing natural history studies. So just giving a quick presentation. We started in 2018 really thinking about natural history studies, and Ingrid came over to the 19 to really think about how can we develop that in the United Kingdom. And what we've got together, really a group of all the child neurologists from all the different centres to plan this. And because we have drugs that are effective at reducing seizures, but if you want to look at cognition, other aspects, we really need good natural history data, and this has to be done prospectively. And if you do that, if you enroll many patients, it also means that you can raise the standards of care that you receive. So we've done this now in pediatric and adult centers, and that's something that I think is important to highlight. It shouldn't just be pediatrics, because all these monogenic epilepsies are lifelong disorders, and it's really important to collect data, lifelong data, to also then be able to show that benefits can be achieved in old age as well. So that's really important. So we have a group of 30 participating sites, and that's cost me many grey hairs to develop this, because even though we've got a National Health Service which works brilliantly, but still you've got regulations in every single hospital, and to setting up a site and to get everybody on board is a lot of diplomacy required. And so our aim was to recruit about 240 children and 60 adults, and we're using it really to also to build and establish adult centers of expertise for Dravet syndrome in the UK. And we're looking at seizures and neurocognitive assessments, but also detailed medication data. And what we do is that we integrate it into routine clinical care, meaning that almost like in cancer care as well, where basically your clinical visit becomes an automated study visit. So you integrate it, and it makes it much easier to actually collect data long term. Everybody gets in the mindset, yes, we need to collect data, and we do it automatically. And that's very powerful once you've done it for a period of time. And we can see that's very effective in, for example, cancer care, where everybody gets automatically enrolled in a trial. And we also do the 6 monthly, but also we have very detailed neuropsychology assessments. The families and the individuals then undergo an entire day of neurocognitive testing, and that's really challenging because these tests can be, often you need to plan for breaks, it might be just too much, the concentration span is not there. To actually do that is really challenging and difficult, and we've got a nice team across the UK who just do exactly that. What we hope is that by doing this, we can also give something back to the clinicians, because the clinicians that are doing this, so once they start collecting data prospectively in a standardized way, we can then, at the next visits, we can actually give them the data back. And they can, over time, they will then be able to see, oh, these are the seizure counts over the last 6 visits. You can see, this is what my generalized tonic-clonic seizures or my focal seizures. And then we can look at how many emergency admissions the patient had, how many ambulance calls, how many days in hospital, and all the medication doses. And we can actually give that back to the clinicians, because what we often do is, once I see a patient, I have to go through back my old letters to see, oh, what actually did I do last year or that, and actually having everything presented to you prospectively makes it much easier to actually make a plan which medications might work. And another benefit, I think, is that we're doing this across the entire UK, meaning that regardless of where you live, everybody has the same access and everybody gets asked the same questions. And that's really important because, of course, if you see Ingrid in Melbourne, then you get a really high-level, very comprehensive assessment. But imagine you have the same assessment everywhere because everybody signed up to this, and actually it doesn't matter where you are because everybody gets the same assessment. And that clearly will raise then the standard of care, the discussions that you have, for example, discussions about SUDEP, which is a really important discussion in epilepsy, and that has to be all tailored. So this is, of course, all that is a team effort. So this is our study team of all the child neurologists. This last November, we had our first meeting, national meeting, with our child neurologists. We have our neuropsychologists, our database people. So a huge group of people coming together to actually work on this, to drive this forward. So I would like to conclude that clearly the genetic causes of Dravet syndrome, that offers the opportunity for precision medicine, but that applies for any monogenic epilepsy. I think that the early reports from disease-modifying therapies and Dravet syndrome, what I showed you, I think that's quite promising and encouraging. One question is, of course, the timing of intervention. That might be important. We don't know yet whether early treatment might be relevant. But of course, precision medicine remains very expensive and time-consuming. And setting up these trials, infrastructure will be expensive. But if you think back, the Human Genome Project, how expensive it was to sequence that, millions and millions of pounds, and now you do it for a few $100s. So I would think that in 10, 20 years' time, developing an ASO and giving it will be much cheaper than it is now. Yeah, so this is just, and finally, just would like to thank all our patients and all the national and international collaborators who've been part of this work. Thank you.